Today I want to go over some of the assessment elements when looking at strain using the Siemens machine. I want to consider a number of different things, such as how do we actually do it, what's sort of the ideal image for it, how many beats to use, do we use an extended R2R, how many times should we actually try to move points around and reanalyze the image, should we be excluding any segments from analysis, what's the difference between endocardial and full thickness strain, and also just touch on RV and atrial strain. So, in terms of how do we perform it, first thing we need to do is make sure the ECG is ideal. It uses it to sort of pick those opening and closing points for the valve, so it can be manually adjusted, but it's a bit laborious, so I wouldn't actually advise going there, better to have a good ECG. You need to have an optimal depth and width. Basically, you want to be able to cover the LV through the cardiac cycle, so you want to make sure the mitral annulus isn't disappearing below your sector, or the LV walls are moving outside the sector and diastole. Ideally, you'd be aiming for the highest frame rate as possible, so you want as narrow a sector as possible, but wide enough that you capture everything. Some say at least 40 frames per second. I generally think at least 50, ideally over 70. But the significant thing to remember is it does go with heart rate as well. Basically, the more bradycardic, the lower the frame rate you can get away with. The more tachycardic, you need a higher frame rate. To actually capture images for frame rate, for assessing strain, you need to consider how we do that. And the best way is actually to freeze and then capture the previous button. This then captures every frame associated with the image, whereas if we do a standard image capture, there's a degree of compression that goes on the machine, and this will actually take that down compared to what the actual frame rate displayed is. So continuing this, we actually need to sort of, before we even decide what we're going to do with it, we need to sort of watch the image throughout the cardiac cycle and think, do we have any parts where we have significant echo dropout? If we do, then we often think, I might probably need to redo that image and really try and optimize that gain frequency in the window rather than just attempting to try and run with it. So what I'll do then, once I have an image, I'll scroll through the cardiac cycle and I'll place cursor points, set a point in the cycle where I actually seem to see good endocardium. And so it might be partly in systole. It doesn't need to be at any particular point. You do need to be careful in avoiding things such as papillary muscles as well as trabeculations. And also you want to go quite down close to the valves, but you just want to make sure you're not getting the valves accidentally in there. At this point, we'll run analysis. Once we are running analysis, then we need to have a look at the border and see how well it really does move through the cardiac cycle. It may look quite good in diastole, but then you might notice the points sort of disappear into somewhere strange in systole. The best thing I find to do is, if you find a frame where it's really tracking badly, is to sort of scroll through to around there and reposition the cursor points in that frame. When you're happy, then you're actually going to capture that picture as well, and you want to be able to demonstrate so the cardiologist can actually see the strain through it. There are also a number of other strain curves that can be displayed as well as the bullseye. In the analysis, you've got various icons that appear along there, and you may choose them, which I'll discuss a little bit later. So in this example here, in diastole, the close to the mitral annulus was tracking fine, but in systole you can see it's just disappeared into no man's land. So then I'd reposition that cursor point down and then rerun the analysis. So what's an optimal image to do one? Well, basically one where you have good endocardium and epicardium visible throughout the cardiac cycle. Foreshortening you've got to be careful with, because it can lead to overestimation of the apical segments and can lead to quite different numbers. Proximal septal bulges, these can be difficult. There are different sort of theories on this. Some think you just stop short as the bulge starts. Other things you just ignore it, sort of go through it and more or less cut across it, which in truth you'll end up doing more myocardial at that point. Generally, I would actually do that in preference. In terms of number of beats and whether we need to run an extended R2R, the Siemens, if you use the freeze and capture method, seems to work perfectly fine without needing to use an extended R2R. Similarly as well on routine, day-to-day, I find I can get away with using one beat for analysis. I generally avoid using multiple beats, just the longer acquisition time with the longer time for it to actually analyse images as well. If you're doing a research study, though, often they will dictate the number of beats required, typically 3 beats. With atrial fibrillation as well, you'll be looking at 2 to 3 beats as well, depending on your R2R. One question is, how many times should we try and reanalyze an image? They sort of consensus up to about 3 times. At this point, we've got different options. We think, well, I'll accept it even though it's not great. It might have a point that's not tracking great, but okay. We can potentially exclude poorly tracking segments, or we could also just re-abandon and try to attempt on another image, or just abandon the attempt to measure strain altogether. So should we exclude segments from analysis? There's pros and cons for this. If we exclude too many segments, it stops really meaning anything in a lot of ways. The actual guidelines do suggest that actually you can move up, exclude up to 1 segment per view. It would also invalidate it if you don't use a strain just because you have 1 poorly tracking segment or 2, so it does have value. There's a question as well regarding strain types, because on different machines you'll see the display differently. Sometimes you'll see the single line that we typically see with the Siemens in terms of the default, but there is an element of whether you can actually track endocardial, myocardial, epicardial and transmural strain. However, they're not equal. Endocardial is highest, epicardial is lower. Part of this is the fact that endocardial strain was decided to be the best match between different vendors, but part of this was also based on the fact that not all vendors had all types of strain for comparison, where they all did have endocardial strain, so that was why it was decided to be relevant in this earlier study between machines. Another element of this is there are different papers that do exist out there talking about different types of strain in different contexts, some talking about some being more useful in different scenarios, and I think we're going to see more and more papers coming out over time that will talk about different strains and different values and what they actually mean. Part of the difference relates to also that fibre orientation between the endocardium and the epicardium. The Siemens default is to have the endocardial strain on, and the initial demonstration for the reps was endocardial, so basically I persisted with that over time. As I said before, the values are different. You need to avoid actually including the pericardium in the region of interest, because then you end up tracking the pericardium rather than the epicardium, which can produce, again, erroneous numbers. This is adjusted by adjusting the width of the actual region of interest in there, the contour. Here I'm just showing you here to turn on full thickness tracking. We have epicontour, which we turn on, and then the arrows up and down will adjust the degree of thickness of that region of interest. We have various ways at which it can be displayed. It will default to endo vectors on, but often I prefer the segmental deformation and the parametric or longitudinal circumferential to be on. You'll play with the different ones and they'll give you nice pretty colours and look more like some of the other machines. So, should we be doing it? Well, I think on a day-to-day basis the endocardial strain is adequate. It's faster. You don't also have the issue of then trying to watch 2 lines tracking and consider having to move and try and make them both work. However, I think we'll find in general that the next generation is probably going to have the speed of processing will be much quicker, and it'll likely be the full thickness as the actual default anyway, so I think in the end we'll probably move that way. If I was doing a study, well, current research, I will continue whatever I've been doing to this point. If it was a new study or new patients in the study, I would consider doing full thickness, because I think it's more appropriate in the research context, because there's just more information of which they can play with down the track in terms of analysing. In terms of right ventricular and atrial strain, there is left and right atrial strain, but most of the data is around the left atrium. The assessment RV strain is still the same issues in terms of sector width, optimal window to actually see the free wall through that cardiac cycle. The main difference is we talk about free wall strain, so you do your normal strain analysis, but you actually switch off the septal segments. Atrial strain, you're finding more and more papers coming out in the literature. There are different elements in terms of strain. They talk about reservoir, conduit, contraction phases, and as I said, it's an emerging area and becoming more relevant though over time. I haven't discussed too much in terms of short axial radial strain. There's less agreement between the vendors regarding it. In terms of documentation, we should be talking about the type of strain, endocardial, epicardial, myocardial, full thickness, what we're dealing with, number of segments excluded if we do, comment if the tracking is suboptimal, because we just want to say, well, it's probably what it is, but it's not ideal. The ranges we talk about, 18, 16 to 18, greater than 16. We talk about less than and greater than in terms of a negative number, so it sort of looks, you always have to think about it when you actually write it down. So who should we be doing on? Well, nearly everyone when you start reading the papers. There are multiple conditions, so that in the papers being described where they talk about the clinical utility of it. We talk about the standard ones of cardiomyopathies, amyloid, clozapine, clozapine and chemotherapy toxicity. And it's also a growing list of other ones. So let's talk much more in terms of valvular heart disease, particularly AS and MR. Detection of ischemia and viability is being discussed. Hypertensive heart disease, LV desynchrony, cardiac resynchronization therapy, you're seeing papers around too. RV strain of pulmonary hypertension or RV dysplasia, LA strain for AF, occurrence and recurrence and thrombotic risk, amyloid, heart failure, etc., because there's multiple papers actually in these areas now. So the final points. Strain is here to stay. It's already in daily use in many, many places. The research is already significant, but there are still lots of gaps and issues, and lots of issues when turn around the vendor differences. But you'll find it continue to grow, and some of these gaps will narrow. Of relevance, you just need to do enough normal patients also to recognise when tracking is just not right. Whether it's actually real or whether it's actually artifactual. Some of the numbers you are seeing. Can be systolic blood pressure does seem to also even cause variance within normal people too, within the normal population. And the prognostic value is growing into multiple different groups, so it starts nearly applying to everybody. So there are various also papers around of note, of which there are many. These are just a few of the most relevant ones.